Let's look at Chapter 8, the cardiovascular system. Quick review of the cardiovascular system. We know that deoxygenated blood enters into the heart through the superior and inferior or cranial and caudal vena cava. From there, it enters into the right atrium. When the heart contracts the atria, then the tricuspid valve opens and allows that deoxygenated blood to go into the right ventricle. Contraction there causes that blood to move up through the pulmonary valve and out into the lungs through the pulmonary arteries. Once the blood's gone to the lungs, has switched its CO2 for oxygen, then the blood comes back in from the lungs into the heart, comes in through the pulmonary veins, the left and right pulmonary veins, into the left atrium. The atrium contracts and the mitral valve opens, allowing that oxygenated blood to go into the left ventricle. The left ventricle contracts and pushes that oxygenated blood up through the aortic valve, which is a semilunar valve. And then, of course, it gets moved to the rest of the body through the aorta and then its branching arteries. Important things to note, the left ventricle is the thickest area of myocardium because in one push, in one contraction, it has to pump that blood all the way down through the body. And likewise too, the mitral valve, and so the mitral valve, also known as the bicuspid valve, and the tricuspid valve, those are atrioventricular valves. They sit in between the atria and the ventricles. And the pulmonic valve, or pulmonary valve, and the aortic valve are known as semilunar valves. The difference is in their shape and the way they are set up in regard to contractions and opening and closing, but this is just a closer look. The tricuspid and bicuspid valves, tricuspid has 3 flaps, bicuspid has 2, and then the aortic and the pulmonary valve have 3 small flaps that come together to prevent blood from backflowing. So the cardiac cycle, systole is the heart muscle contracting. The blood is ejected from the atria to the ventricles, then from the ventricles to the arteries. In diastole, that's when the heart is overall relaxed, so it relaxes and it refills with blood to be ejected during the next systolic contraction. The sinoatrial node, as we've discussed previously, is a specialized area of cardiac muscle cells, and they're located in the right atrium. So if we look at this image here, they're in a little bundle, specifically within the wall of the right atrium. The sinoatrial node generates electrical impulses that trigger repeated beating of the heart. The heart cells beat at the rate of the fastest cells. So what we do is we call the sinoatrial node the pacemaker because the cells within the sinoatrial node are the fastest to receive impulses and the fastest to contract. So with that, all the other cells will contract based on the fastest cells. So the sinoatrial node technically is setting the pace. And then of course we've got depolarization and repolarization. Depolarization is of course the process of generating electrical impulse from the sinoatrial node, and this results from movement of cations across cell membranes. So the cations that we're talking about are sodium, potassium, and calcium into the sinoatrial node, and this happens during systole. Polarization, the cations are pumped out of the cell, and this results in the outside of the cell having a more positive charge than the inside of the cell. This happens in diastole. So calcium we hadn't mentioned a lot previously in regard to polarization and depolarization. Once the muscle cell is triggered to act, the calcium is released into the cell to really start the contraction process of the actin and myosin. So keep that in mind. The sodium and potassium are responsible for the shift between polarization and depolarization, and then once that depolarization occurs, calcium is released to the cell and has an actual effect on the actin and myosin filaments. The cardiac cycle, an impulse is generated at the sinoatrial node and it travels from one muscle cell to the next in a wave pattern. It initially causes both the atria to contract, the blood is pushed through the atrioventricular valves into the ventricles, and the impulse also travels quickly down the muscle fibers to the atrioventricular node. Electrical impulse then spreads through the bundle of His, which are the fibers in the ventricles, travels down the interventricular septum to the bottom of the ventricles. These Purkinje fibers then carry impulses from the bundle of His up to the ventricular myocardium. So if we look at normal cardiac function right here, this is the cardiac cycle itself. So we've got stimulation of the sinoatrial node, which sets the beat of the heart, sets the rhythm. The atrioventricular node then is stimulated. That electrical impulse travels through the atrioventricular node to the bundle branches, to the bundle of His, and then through to the bundle branches, and then ending at the Purkinje fibers, which then sets the tone for the ventricles. So it passes on that electrical input to the ventricles. So through all of these processes, we get contraction of the atria and the ventricles. The way we measure electrical impulse throughout the heart is with an electrocardiogram, so an ECG, and we have basic components of these, which we'll go through in a second. But essentially we use the PQRS wave to identify electrical abnormalities in the heart. We can't really identify specific physical abnormalities with just the ECG, but sometimes they can give us a clue as to where the issues lie. So we can detect an increase in cardiac muscle mass with cardiomyopathy and congestive heart failure. So the ECG tells us about the electric conductivity within the heart, but it won't specify if cardiomyopathy is at play or congestive heart failure, but otherwise we can't tell that there's a tumor or something in the heart based on the ECG. For that, we would need to go through with cardiac ultrasound to look at the soft tissues inside the heart. So here's a little cartoon to help understand cardiac conduction. The electrical impulse generated at the sinoatrial node stimulates the atria to contract. The impulse travels to the atrioventricular node where there's a brief delay. Then it sweeps to the bundle of His and divides into the left and right bundle branches. Conduction to the Purkinje fibers causes contraction of the ventricles. And there you go, we've got contraction of the atria and the ventricles. There's our beats. So if we break that down a little bit, looking at our waveform specifically, the waveform includes the P, QRS, and T. P is the atrial contraction, so we can see an increase in electrical activity during the atrial contraction. QRS complex is ventricular contraction. And then T is the repolarization period. So it's important to note too, there's a pause in between the P and the QRS complex, and that's the impulse working through the atrioventricular node into the ventricles. So it has to pass from sinoatrial node to atrioventricular, to the bundle of His, to the bundle branches, and then through to the Purkinje fibers, which connect that electrical impulse to the ventricles. In order to measure these impulses, these electrical impulses in the heart, we have to apply ECG leads, of course. And depending on the type of unit that we're using, they have numerous types of leads, typically either 3 or 4. So a little way to remember, if we're using a 3-lead system, which most of them are a 3-lead system, I find in regular veterinary medicine, we can use the little analogy white on right and smoke over fire. So what that means is that the white lead, if we look at this dog here, the dog's in right lateral, the white lead is on its right elbow, roughly, or right axillary area. The left leg, so the left hind leg, has the red lead, so that's the fire, and then the left upper leg, front leg, has the black lead. So again, we've got white on the right, and then we have smoke, the black, over the fire, which is red. Just a little memory trick, because it gets tricky. We have so many different things to remember as we go to our daily business as registered vet techs. So the cardiac cycle, the atria begin diastole while the ventricles are still contracting, and that's why we get that lub-dub, so that sort of pause in between the two sounds. The pressure in the ventricles is higher than the pressure in the atria, and this causes the atrioventricular valves to snap shut. In systole, the heart muscle contracts, as I mentioned before, and in diastole, that heart muscle relaxes to allow refilling. The atria then fill with blood during diastole, As the atria are becoming completely full, systole ends in the ventricles, and the aortic and pulmonary valves snap shut. Pressure in the ventricles falls below the pressure in the full atria. The atrioventricular valves are opened, the ventricles fill with blood, and the sinoatrial node depolarizes again, which causes the atria to contract and restart that cycle all over again. So I'll post these videos to the YouTube page, and they're also on your hard copy of your PowerPoint, so the digital copy if you'd like to review them. But otherwise, I'll post them to our playlist if you guys want to check them out. So when we're looking at fetal circulation, of course, it's quite different than that of a fully grown adult circulation. And I guess I should specify too, it's probably clear, but in case not, right now I'm only talking about mammalian circulation, because as the animals change to amphibian or otherwise, avian too, we start to get, of course, species variation in their cardiac system. So we're just focusing on mammalian cardiac systems. Fetal circulation, of course, it's underdeveloped, and there's bypasses in the fetal circulation that keep most of the blood out of the pulmonary circulation because they don't have fully developed lungs yet, which are oxygenating the blood. The fetus receives oxygen from the mother through the placenta. Oxygenated blood flows from the placenta through the umbilical vein, and the blood from the umbilical vein flows through the liver and the ductus venosus into the caudal vena cava for recirculation. Blood from the caudal vena cava enters into the right atrium. Most of the blood from the right atrium flows directly into the left atrium through the foramen ovale, which is the opening right here. So the oval foramen, that's the opening in the atrial septum. Blood from the caudal vena cava enters the right atrium. Most of the blood then flows directly into the left atrium through the foramen ovale. Some blood flows through the tricuspid valve into the right ventricle and then to the pulmonary artery. So moderately different, of course. We're not entering into the lungs to acquire oxygenated blood. Blood from the pulmonary artery flows into the lungs or through the ductus arteriosus directly into the aorta, and blood travels through the fetal aorta to the fetal systemic circulation. Lastly, deoxygenated blood is sent back to the placenta through the umbilical arteries. After birth, the ductus venosus constricts, and the foramen ovale and ductus arteriosus close. So, of course, there's one physical abnormality, which is a fetal septal defect that can occur, whereby that oval foramen, or the opening in either the atrial septum or the ventricular septum, remains open after the animal has been birthed. So that is a defect. It's a congenital defect. It's not uncommon, and it happens in people as well. So it could be a ventricular septal defect or an atrial septal defect. And essentially what that means is in the fetus, the blood is able to cross through those barriers. So it can go from one side of the heart to the other, which of course increases the risks for things like blood clots and poor circulation of the blood itself. Surgery is most often required for that, and of course it depends on the size of the hole in the heart. If it's a large enough hole that's causing issues in regard to circulation and the potential for blood clots, then surgery would be warranted. So we'll talk about normal heart sounds. Every heart sound generally should sound lub-dub. Lub is the first sound, which is closure of the mitral and tricuspid valves at the beginning of ventricular systole. Mitral valve is the loudest on the left side of the chest, and the tricuspid valve is best heard on the right side of the chest. So typically when we're listening to the heart, we listen between the 4th and 6th ribs for dogs and cats, roughly, or 5th to 7th ribs, and we often listen on the left-hand side of the thorax. Cats, oftentimes we can auscultate the heart pretty well if we listen almost toward the sternum, so a little bit more medial. We can get a good appreciation of the sounds. The second sound, the S2, the dub, is the closure of the semilunar valves at the beginning of ventricular diastole. It's easiest to hear on the left side of the thorax. I'll post these as well. These are some links for normal canine heart sounds and murmurs. I'll post them to the playlist. Large animals sometimes have additional heart sounds, which can be an S3 and S4. S3 is a rapid ventricular filling, and S4 is contraction of the atria. And then this link here is in regard to a Clydesdale who had to go on some cardiac medication because it had an abnormal heart sound. Cardiac output is the amount of blood that leaves the heart, and it depends on stroke volume, which is the amount of blood ejected with each cardiac contraction, and heart rate, which of course is the frequency of heart contractions. Cardiac output overall equals that stroke volume and heart rate. Vigorous exercise results in an increased contractility, increased stroke volume, and increased heart rate. Starling's law, increased filling of the heart results in an increased force of cardiac contraction and increased stroke volume. Reduced blood pressure, such as shock, in cases of shock, hypovolemia, there's less pressure to fill the heart, so there's decreased stroke volume. And in the cases of a drop in blood pressure, the heart rate will increase to compensate for a decreased stroke volume. So it will increase to a degree, and then of course, if the heart can't compensate, over time it will start to decrease, which is a big problem. It means that the hypovolemia is really affecting the body, and that animal might be on its way out. Cardiac output is under the influence of the autonomic nervous system. So of course we know that the sympathetic nervous system is responsible for that fight or flight mechanism. It releases epinephrine, and epinephrine's result on the heart, of course, is an increase in stroke volume and heart rate. During general anesthesia, the opposite happens, and the parasympathetic nervous system releases acetylcholine. So acetylcholine on skeletal muscles causes an increase in contractility. Acetylcholine on the cardiac muscle causes a decrease in heart rate and a decreased stroke volume. So again, parasympathetic is responsible for rest and recover. Vascular anatomy and physiology, the blood in the systemic circulation is under higher pressure than the blood in the pulmonary or coronary circulation. So by pulmonary, I mean going to the lungs, of course, so back and forth from the lungs. And coronary circulation, we're talking about the coronary veins and arteries that run alongside the outside of the heart. So those are the arteries and the veins that supply oxygenated blood to the actual myocardium and then take away the deoxygenated blood for uptake into circulation. Of course, this makes sense because more pressure is needed to carry the blood throughout the body, hence systemic circulation is under higher pressure, and blood in systemic circulation encounters more resistance to flow. The aorta is the largest artery in the body. It's the largest in diameter, and it has the thickest vessel walls. The artery wall layers are similar to the walls of the heart themselves. The aorta and the pulmonary arteries, the middle layers contain more elastic fibers than muscle fibers, so they allow for stretching and compensation of large volumes. Vascular anatomy, the venous blood is under lower pressure than arterial blood. Vascular anatomy, venous blood is under lower pressure than arterial blood. Veins have thinner walls and arteries, and valves in the veins ensure that the blood travels in only one direction toward the heart. We also know that veins use the skeletal muscle pumps of the body itself to help move blood around. And of course, a key difference between veins and arteries, veins do not have pulses, whereas arteries do. Veins in the foreleg merge into larger and larger vessels to form right and left brachycephalic veins. These carry blood to the cranial vena cava and then back into the heart. The veins in the hind limbs merge into right and left iliac veins. Think about the wings of the ilium or the ilium itself. That's where we get the term iliac from. These carry blood to the caudal vena cava. Caudal vena cava then travels up to the right atrium. Smooth muscle walls are in the walls of most blood vessels, and that is the Smooth muscles in the walls of most blood vessels exist, and that is the multi-unit smooth muscle for the most part. Constriction and relaxation allows the vascular system to direct blood to different regions of the body under different circumstances. It also has the opportunity, if we think about it, to close down peripheral blood vessels, such as peripheral veins and capillaries, in times of shock to redirect or reroute that blood back up to the important organs, the brain, the heart, and the lungs. And then, of course, venipuncture as per your anatomy slides.